Alrighty, we might make a start. So welcome everybody. Today is a really important day for West Vic PHN to celebrate the conclusion of this phase of the SPIDAH project and a presentation and a final report that we're calling Inclusion is Limitless. I'm Aunty Giddy, Executive Director of Strategy and Engagement at West Vic PHN. And just to note for everybody that this session is being recorded to be shared with other people in the future, and it will be made publicly available. I'd like to commence by acknowledging the traditional owners and custodians of the lands and waterways, the Gulajan, the Wadawurrung, Gulajan, Gadibanug, Nud, Kirewurrung, Peekwurrung, Gunditjmara, Jabwurrung, Watchabullock, Jajawurrung, Jadwachali, Wagaya, Jukgulk, and Jadwa peoples. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations, and acknowledge all the lands that everybody's joining on from today. We'd also like to acknowledge people with lived experience of disability, including their individuals, their families, support workers, and advocates. We recognise their strength, courage, and unique perspective as a vital contribution to our work to learn, grow, and achieve better outcomes together. Okay, so we've got a great set of speakers today, and this really represents the breadth of what the SPIDAH team has been able to do over the last 2 years to really cast a wide net and get expertise from right across the sector to make sure that we can actually deliver outcomes for people with disability within our region. So I'll introduce each of the speakers as we go. Some of our speakers are joining us through recorded presentations. Some of them are going to be with us live today, including Andrew and Miranda. We'll work our way through as we go. So I'd like to start by introducing the two stars of the show from our point of view in West Vic. Kerry and Nicole have been the driving force behind the SPIDAH project over these last couple of years. Kerry came to the SPIDAH project with a very strong understanding of disability, having had a family member with complex needs, and spending probably the last 30 years working across a range of community service, disability and mental health programs. As you all know, Kerry is a very strong, passionate advocate for promotion and inclusive practice for all members of the community. Similarly, Nicole brought a lot of experience working as a local area coordinator, partnering with NDS, and has a strong interest in the health sector responsibilities, and has really shone through this process running the project together with Kerry. So I'm going to ask Kerry and Nicole to give us a bit of a run through of the final report and some of the highlights over the next half hour. But I'll hand over to Kerry. Are you starting, or Nicole?
I'm kicking off. Thanks, Aunty.
Thanks, Nicole.
So the project we're speaking about today forms part of the 10-year national roadmap for improving the health of people with intellectual disability. The beginnings of the roadmap came about from roundtable discussions hosted by Simon Cottrell from the Department of Health and Aged Care, and a collaborative approach with detailed consultations with stakeholders. We'll now play a short video developed by the Council for Intellectual Disability, CID, of Laura and Jack speaking about the national roadmap.
Australia's healthcare system is one of the best in the world. Most Australians consider themselves to be in good health.
But health outcomes are so much worse for people like me, living with intellectual disability.
Between 1 and 2% of people have an intellectual disability.
We experience double the avoidable deaths, worse physical and mental health,
Lower rates of preventative health like vaccinations.
many of us use multiple medications.
An Australian study found, on average, we die 27 years younger.
Many of us have complex health conditions that are difficult to diagnose.
And sometimes the signs of illness are not so clear.
Communication can be harder in both directions.
But we want to be healthy, and
We have right to good health care.
Thanks, Laura and Jack, for that video. Some of the actions within the first 3 years of the National Roadmap were attributed to the Primary Care Enhancement Program, or PCEP, as a pilot. The PCEP acknowledges many health professionals have limited training in providing comprehensive healthcare to people with lived experience of intellectual disability. The aim of the pilot was to build the capacity of primary healthcare professionals in delivering high-quality healthcare for people with an intellectual disability and to support the health literacy of people with lived experience and their supporters. To underpin the activities of the PCEP, 4 primary health networks were funded by the Department of Health and Aged Care. These were Central Eastern Sydney, Central Queensland, Wide Bay and Sunshine Coast, Tasmania and Western Victoria. As you can imagine, each state has very different needs when looking through a primary care lens. So to support the variations, each state worked across the area they covered, along with some state and national collaboration and sharing of resources. The Australian Government also appointed ABT associates to evaluate the 4 PHNs and collate the work they were doing with a view of sharing the work and initiatives with other PHNs and programs to look towards sustainable opportunities. We'll put a link to a survey in the chat that we kindly request attendees to complete to reflect on today's event. And this information will go directly to ABT associates, and de-identified data would be provided back to the SPIDAH team. At the Western Victoria Primary Health Network, this project was called SPIDAH, which stands for Supporting People with an Intellectual Disability to Access Health. Today's event, Inclusion is Limitless, is about sharing the work of the SPIDAH project and the final report, which is publicly available to the community. The infograph on the title page of our final report was selected as it's a visual representation of the connectedness between the health, disability and other sectors. The SPIDAH project was initiated with a co-design process, engaging with people with lived experience of intellectual disability, supporters, health professionals and relevant others. The results from the co-design are outlined in the foundational project report, and as you'll see here, the 6 key themes were accessibility and reasonable adjustments, workforce, mental health, creating safer communities, preventative healthcare, and the interface with other sectors. These formed the parameters of the SPIDAH project and were considered throughout this project journey. We're also fortunate to have worked alongside many strong self-advocates and people with lived experience. Aunty Jane was a member of the team throughout the SPIDAH project, and she created this painting as her representation of what the project means and is called Groups Getting Together.
The first work stream is workforce training and development. The content was guided by the SPIDAH reference group, who are acknowledged on page 7 of the report, and most of the webinars and community of practice sessions were facilitated by Dr. Robert Ward, who is a general practice with support from our own workforce development team. This saw the development of the inclusive practice and reasonable adjustment playlist, which includes over 64 videos, recordings featuring high-skilled subject matter experts covering a wide range of health topics targeting primary healthcare professionals and those they interface with. Some of the topics covered were a fresh look at disability, communication, consent, decision-making and legal aspects, pathways to diagnosis and paediatrician GP service interface and transitions, annual health assessments, of which we've developed some videos on that, or Professor Nicholas Lennox certainly helped out with that, positive behaviour supports and trauma-informed care, dual disability, intellectual disability and mental health, cardiometabolic disease risk, impact of diet, digestive systems, oral health and pharmacy, occupational health, occupational therapy, speech therapy and diabetes, and case conferencing and case coordination. The playlist is accessible directly from the report through the hyperlink and is also available via the Western Region PHN Learn YouTube page. I had the pleasure of delivering a face-to-face education sessions with Aunty Jane, predominantly across the Western Victoria region, but we also had others attend the training from other states. And this was inclusive of reception staff training, training with OT, speech pathologists, dentists, pharmacists, mental health professionals and other members from the community. The emphasis for the training was on inclusive practice and reasonable adjustments from the lens of a person with lived experience, being Aunty Jane. The training covered end-to-end touch points within the professional environment, and Aunty Jane will share some of that information about the training later on in her presentation. Western Victoria PHN worked in collaboration with the Victorian Dual Disability Service, St Vincent's Hospital, to deliver a mental health curriculum training targeting primary health care professionals and relative others in dual disability. It was reported through the attendees' feedback that the information shared assisted in better understanding that some changes in practice are required to tailor assessments and provided supports in a timely manner and in line with the newly emerging mental health legislation. This was successfully delivered not only to federally funded commission services, but also other states and territories that were interested in the subject matter to support their learning and upskilling. Further to this, training was also delivered by a UK subject matter expert, Steve Moss. In particular, the Moss Pass checklist will support people with lived experience and their supporters to accurately identify signs and symptoms of mental health as described in the DSM-5 to better support referral pathways. The Moss Pass tools are validated and used worldwide and were certainly described as being a welcomed addition by those that have attended the training to prevent diagnostic overshadowing. The tool is also relevant to any cohort inclusive of children and people with dementia that may have presenting concerns of mental health. The second work stream is health pathways or care pathways that provides GPs and primary health care providers with evidence-based, up-to-date clinical guidelines, referral information and resources. Content relevant to supporting the health of people with an intellectual disability has been updated by the team and GP clinical editor from Western Victoria, PHN. These key enhancements have been the collaboration between Western Victoria PHN Health Pathways and the Royal Children's Hospital in Melbourne on cerebral palsy. The other two areas that have been embedded within Health Pathways are the Comprehensive Health Assessment Program, otherwise known as the CHAP, that is also now available for young people aged 12 to 18, that has been made freely available by the Department of Health and Aged Care for GPs to use. The other area is transitioning from childhood to adult, as there are many complexities during this period We also have webinars featuring experts that speak to both of these areas. Information resources were a key feature of the SPIDAH project, and the tools were developed to connect doctors to their patients. The patient profile provides the clinical team, inclusive of GP and referral points, on how to best communicate and connect with the patient, including any reasonable adjustments required and the role of their supporters. Other tools include a signs and symptoms tracker, so people can start to think about when did a person start to display a change in behaviour or any other indicators that might suggest there is a problem. Does it happen at a particular time of the day or night? And this will bring specific information that has been observed from the person or their supporters to assist the GP in making a more accurate diagnosis. Another feature is an editable, easy-read chronic healthcare plan template. The template can be used by GPs and other allied health professionals involved in a wraparound model of care using case conferencing and coordination. This will ensure all are on the same page to give the best healthcare and achieve the best outcomes for the patient. This also lends itself to a preventative approach to keep the person well while providing comprehensive healthcare. There's also a list of MBS items relevant to primary healthcare professionals and psychiatrists on the Practice Connect page to support a business model lens with live descriptors to ensure all auditing requirements are covered. And of course, that is about intellectual disability. The final work stream of SPIDAH project was engaging and advocacy. This section showcases some of the length and breadth of engagement and collaboration between the SPIDAH team and others. We developed and funded some trial activities that led to the development of frameworks for GP clinics and mental health services and in the use of a telehealth by people with lived experience. The GP clinic framework, called Continuous Quality Improvement Framework towards Inclusive and Equitable Healthcare. This was developed out of a trial activity undertaken by Golden Point Medical Centre in Ballarat and Health E Medical Centre in Geelong. Each clinic completed an organisational audit or touch point and identified improvement opportunities to enhance inclusive practice within their clinic. Tips and recommendations from the trial organisations are included in the framework. Some examples are pre-admission, where a digital copy was used that could be sent to a family or supporters to complete prior to attending the medical appointment at the clinic. As you can appreciate, it would be very difficult to have a young person or a person with a disability while you're trying to fill out paperwork. So that was important to this clinic to attend to that issue. The second was streamlining processes for improving the annual health assessment for people with an intellectual disability, the CHAP as referred to earlier. This involved the clinic undertaking a data cleansing process to identify who were eligible for this assessment with specific MBS items. The framework provides not only an approach for enhancing access for people with an intellectual disability, but also for all other members of the community. The mental health framework is supporting inclusive practice framework for youth and adult mental health services. The initial trial activity was undertaken by Headspace Warrnambool, Brophy Family and Youth Services through the implementation of a youth peer support worker with lived experience of a disability to support young people in accessing local mental health and wellbeing supports. The first steps were to undertake an audit, inclusive of looking at policies and each patient touch point to access the service, considering the use of language and any reasonable adjustments required. Here, the service also undertook easy read training so they could undertake their assessments using a range of communication techniques. The trial saw delivery of education and training for both staff and upskilling for young people, as well as the development of a large suite of easy read resources for young people about understanding mental health and services available to them, which features in the appendix of the report. The framework provides the recommendations from the trial organisations and has been broadening to support inclusive practice across both youth and mental health service settings. The framework of the telehealth peer support worker was created from the trial activity also undertaken by Grampians Community Health, who employed a person with lived experience of a disability to support people with an intellectual disability and their supporters in the use of telehealth to access healthcare. This was done in a step-by-step process, from helping the person to link to the internet, using Google Maps to navigate, using their calendars to track appointments and connect with clinics for their appointments. The trial also included the delivery of a podcast, episodes on various health topics, which are accessible from the framework document. One of the highlights of the SPIDAH team was at the completion of the trial activity, the person employed by Grampians Community Health, Letitia Stevens, was successful in stepping into a leadership role in the organisation post that framework activity. Congratulations, Letitia. The SPIDAH project connected with a range of community groups and services at the interface between health and other sectors. These are displayed on the current page, which demonstrates the reach of the project. The report ends with lessons learned and a conclusion, and talks about how during the time of the project there were changes in the National Disability Insurance Scheme Act, the tabling of the Royal Commission report, and the realisation that while the work of the SPIDAH project and the other PCEPs and broader community groups has increased awareness, it has also highlighted that there is more work to be done, and together we'll create the next steps as inclusion is limitless. Thanks, Andy.
Thanks very much, Kerry and Nicole. I was just thinking, Kerry and Nicole, maybe in the chat you could pop the link to the final report so that people have got easy access to it. That'd be great. And just an amazing amount of work and engagement across the project. So congratulations to both of you. We're now excited that we have one of our, I guess, favourite people from the SPIDAH project. So Aunty Jane Rosengrave is going to join us and provide a little video for our next session. Aunty Jane has lived experience of intellectual disability, and she's a strong self-advocate and identifies as a First Nations person from the Yorta Yorta lands, which is up around Shepparton for those who don't know. Aunty Jane has represented Australia at the Special Olympics in swimming, and amongst other things, she was the recipient of the Tony Fitzgerald Memorial Award at the Australian Human Rights Awards. This is awarded to a person with a track record in promoting and advancing human rights in the Australian community on a not-for-profit basis. So Aunty Jane has been supporting the SPIDAH project on the reference group, and also as a direct training delivery member, co-facilitating alongside Kerry. The inclusive and best practice in healthcare for people with intellectual disability presentations have been undertaken more than 25 times across regional Victoria, with hundreds of GPs, practice nurses and allied health professionals participating in those events. So a huge component of our project. So I think we'll now run a short video from Aunty Jane.
My involvement with the SPIDAH project was for me to come along with a person with an intellectual disability to talk to the staff and to the workers who work with people with a disability about their experience of going to the doctors, to the police, to the when the ambulance have to deal with them, and that they have to be a lot more patient and speak in their language or take their time to listen to them and to understand what they are saying and to make sure that they are feeling welcome and comfortable on when they go and see these doctors or ambulance, when they have to deal with them, or the police or the fire brigade or all that. Kerry and I, we travelled around Victoria, we did, and we went to different organisations in the Wimmera like Horsham, Stawell, where else did we go? Warrnambool, all those type of places. Geelong, we went to, and what we did, we done this training on showing these clips on people with a disability, on what they have to learn and be patient to understand what people with an intellectual disability are going through when they have to see these doctors and nurses, and how they can help them along. So when people with an intellectual disability, there's these different feelings that they can have, or different you know, where they might not feel right. So with the reception staff, what they have to do is go down to their level and to listen to the person when they come to the desk. They have to ask them what their name is, who are they seeing, and if they want to sit down with the other people that are in the clinic, or if they feel safe to sit somewhere else, and if they feel safe somewhere else to sit, they have to make sure that they feel very comfortable, and to give them a drink of water as well. And if they've got a staff member with them, not to look at the staff member, but to look at the client, because it's the client's patient appointment, not the staff. The staff's just there for them to ask them if they need support. Okay, my learning I'd like to share is for people who have been to these meetings, the ones who, like all of them who've come, some of them they've said they have got a lot from these meetings for what I've given them and what I have shared from my experience. And as well, people who are willing to come to these meetings to learn from people who have been through that bad stuff to what it is now, and to learn that we are there to give them our experience and what we've been through, and for these doctors and nurses who never listen to us, which they have to now, and to give them a chance to strengthen their voice and their power to learn from these people who have got intellectual disabilities as well. Yeah, the police needed to come to these, and doctors, which we didn't hardly get any doctors, and police, which they should have come to these meetings as well to learn the ropes on what we have been through, and to be more understanding for Aboriginal people, Torres Strait Island people, for people with a disability in the Aboriginal culture as well, and people who are not Aboriginal as well, to learn by them and to put themselves in our shoes on what we went through. First, we need to try and get more money for this group, this SPIDAH group, because if we don't get any money, what are we going to do? We're going to not have them learning what we've been through for people with a disability, and with doctors and nurses, and the place with pictures. being patient, reception staff, the dentist, anything like that, that they have to be patient. Take note what people with a disability are saying. If they don't understand, just to ask them, what do you mean to be, and people who are physical disabilities, who are in wheelchairs, to try and understand what they are saying with their sign language, and that, or if they can't speak, to show them pictures, to be patient with them and to help them along as well, because body language gives a lot away when people can't speak, because you have to understand what they are saying, not to talk to the staff that's with them, talk to the client too. So it'd be a good idea, I reckon, to do role plays next time for these people to put themselves in our positions on what we went through, and to learn. That's the big question, is to learn what we went through, and for people with a disability on different languages, pictures, sign language and all that, that they can get a lot from people with a disability than what they thought. And the person has to trust them as well, to make sure that they can they feel safe with that person, and have that same person going with them all the time. You know what I mean? Because then that person gets to know their life, that they can be trusted. Yeah, not to swap people over all the time, because they think that they are, what's the word, you know, that they have to start all over again with their life, and they don't want to. I think it is all health professionals that should be trained, even if you're young, you're old, it doesn't matter with age, it doesn't. If you're going to work with people with an intellectual disability, you have to get that training in and understand the ropes on what people with a disability are going through in their health problems as well.
Great, thanks, Aunty Jane. She's always such a passionate advocate as we go through, and I think that continuity of care and the time to develop relationship is just so important in this space. I'm not sure whether Aunty Jane is actually online with us today or not, but maybe as we get further into the presentations, we might have a chance to say hello if she's there.
She's actually unwell, Andy. We spoke to her yesterday. She had every intention of coming, but she's unwell, so not in attendance today, unfortunately.
It's a shame. Alrighty, we might move to our next presenter. And again, this will be a recorded one because Robert had other commitments today. But Dr. Robert Ward is a general practitioner, has been a facilitator on the SPIDAH online education sessions through the ECHO programs and webinars that we've done. He studied medicine at Melbourne Uni and returned to Geelong as a resident at the Geelong Hospital before commencing in general practice 27 years ago. And about 25 years ago, he was introduced to the world of intellectual disability following the birth of his son. He's been a board member of Gateway's support services for the last 23 years, and he has experience of disability from the perspective of a busy general practice, through the eyes of a parent and the challenges of a large provider of disability services. So a pretty unique perspective. He has seen a seismic shift in the landscape for disability since the creation of the NDIA a number of years ago. More recently, he's been involved in the SPIDAH project, exploring the challenges faced by people living with intellectual disability and the health disparity that they experience. So we'll cross to the recording from Robert now.
Hi Andy, and hi everyone. Thanks for that introduction. I wanted to share with you today the SPIDAH project from the perspective of a GP who's been involved with the project from near the start. I'm a full-time general practitioner who works in Geelong, and I've got a 27-year-old son with an intellectual disability, so that's probably why I was caught in this spider's web to be involved in this project, and it's been a wonderful experience. Before I begin, I'd really like to thank Kerry and Nicole and congratulate them on the SPIDAH project and all the hard work they have done. It has been a wonderful project to be involved in. And it's always nice to remind ourselves that the SPIDAH project is the West Vic PHN's initiative to support the capacity of the primary care system to support and deliver better services and better outcomes for people with an intellectual disability. So just very briefly, my personal journey with the SPIDAH project was to be involved in the early meetings and then to be involved with some training sessions through webinars and through the ECHO project, which was meant to bring together GPs and primary healthcare professionals to learn and discuss various subjects related to people with an intellectual disability. Also managed to present at a number of conferences for paediatricians, and had some ongoing involvement with the Office of the Senior Practitioner and with helping develop some changes in the CHAP tool. I suppose through my involvement with the SPIDAH project is we got to work with lots of different health professionals, all of whom have special interests and in treating and looking after people with an intellectual disability. And we met through our meetings, participants and parents and paediatricians and public health experts and service providers, all of whom are involved with looking after people with an intellectual disability. I've just put up a list here of all the other health professionals we dealt with, and all of whom presented at our various set webinars, all with fascinating stories. And probably what I wanted to do is just to highlight a few of them, which for me as a general practitioner gave great value. And firstly, with the speech therapists, and I suppose the whole thing came down to communication and how people with an intellectual disability communicate, and how we as health professionals can listen, and how we as health professionals can also communicate with our patients. And one of the big themes throughout a lot of these sessions was having open communication. And if we don't give our patients the tools to communicate, then it's very hard for us to make diagnoses, it's very hard for us to look after their health, and it's very hard for us to explain to them or to give them information that gives them better knowledge to look after their own health. And the speech therapists certainly highlighted this. I think it's very important when we're helping look after people with an intellectual disability that we use language and all available means to make sure that we are truly listening to what they are trying to tell us, even if it's not with words. The other group I found fascinating as a GP talking to with the dietitians, because often we forget about diet as a really important basis for health in our community, whether that's from increased risk of heart disease and diabetes and preventable health issues into the future. I think the dietitians really highlighted that the importance of a good, healthy diet, and often people with intellectual disability struggle to be able to maintain a healthy diet, whether it's through their health literacy or whether it's secondary to the care we provide them with the carers who help look after people in the community, not being educated enough as to what is a satisfactory dietary input. The other group I'd just like to highlight is the behaviour support practitioners, particularly with people who display various behaviours that can be of a concern to us. And often in the past we've been tempted as medical practitioners to medicate or to what we call chemical restraint. And now there's a whole range of professionals with skills that have been able to support people with an intellectual disability with their behaviours and to support those people looking after them with other strategies that don't necessarily require restrictive practices, in particular medication, as been a theme throughout this process to try to reduce restrictive medication in people with an intellectual disability, which is really sort of inappropriate these days. And so to make use of really well-trained behavioural support practitioners was an important message for me as a general practitioner. I just wanted to highlight some of the themes and messages that came out with the series of webinars that we did. The first one really struck me was the term reasonable adjustments, which I had never heard of before I started out with the SPIDAH project, and I suspect a lot of my GP colleagues may not have heard of it to this day. And what it is those adjustments we do to our regular practice to make it more accessible for people with a disability, and particularly in this case for intellectual disability. And as one of the participants in our seminar said, it is the small things that we can do that can make a huge difference to accessibility. And look, some of the things are even trying to avoid some of the things that we've done in the past, like not acknowledging people with intellectual disability as having ability to make their own decisions and to talk to their carers or to defer to their carers, and to make just that adjustment of actually acknowledging the patient and to see if there's ways that we can improve that communication. And it goes back to the communication we mentioned before with the speech therapists. How do we adjust our practices to give our patients the correct information they need so they can have better control of their health? So small things that can make a big difference, and we should all think about them within our practice, not just from a health professional point of view, but from our reception staff to our systems in our practices. The other interesting time, and I thought and also something I hadn't thought of in the past, is the importance of transition periods, particularly the transition for people with a disability from the childhood system of paediatricians and childhood supports into the adult world of day programs and often more difficult to access health services when they're away from that paediatric population, and that can be a really difficult time. And it also got me thinking about the whole intellectual disability is a lifelong condition, and it goes right from very early childhood through adolescence and right into old age. And the risks of those transition periods are great, and there's risks of losing health information, there's risks of just disconnecting with services. And I think the general practice can have a really important role in trying to hold all those together and hold that information through a whole lifetime. Because if you think about it, the GP or a GP practice with holding good records from very early on and maintaining those records and transferring those records in an appropriate way is probably the only one place where that health record is going to be maintained when a person gets into an older age group. And finally, the other thing, the important thing of annual health assessments. And we dealt with this with the CHAP tool and how that can improve people's access to health by just having that annual health assessment. So we pick up health issues before they develop into long-term health problems. You know, it was really good being involved with all those specialists, and you felt really good when you're in those seminars. And then you get out into the real world of being a GP, and you're sitting in your room here like this, and you realise just how isolated we are. And I suppose some of the issues that came up for us is the training. We don't have a lot of training. We certainly don't have training in medical school. We don't have training postgraduate, or not a lot anyway. And there's huge gaps in our knowledge. And even if we look at things like the annual health assessments, some GPs would be well and truly on top of what a CHAP tool is, and some have no idea and would resist when a carer comes and says, I need to do an annual health assessment on my patient, because they can't see why they need to do that. The other one is support. You know, there's not a lot of support out there. There's certainly no specialist services. Like most of the things general practitioners, if we get into something that's a little bit more complex, we can ring our local specialist. There's nothing available in intellectual disability. Resources, it's hard to find resources. I know that the SPIDAH team have done a great job at putting together more resources, and hopefully that's something in the future that will be more prevalent and easier to use. And also funding. Although Medicare does give us funding for things like annual health assessments and case conferencing, they're hard to use, they're cumbersome, they need a lot of planning, and unless you're doing it all the time, they're hard for GPs to do as a one-off and to support our patients. The other issue that's an ongoing thing is communication. It's often quite fragmented, especially since the NDIA. As soon as an allied health professional is funded through the NDIA, then the GP doesn't get any communication. It's not something that we see. And so that collaborative practice is often not there in the real world. Moving forward, it's been great, I think, the SPIDAH project increasing the awareness of intellectual disability and increasing training resources, and hope GPs will be able to access those in the future. The Westvic PHN has the health pathways, which is always a great resource for GPs if we're keen to look and to know where to look for that. It's great to see the disability liaison officers at the University Hospital in Geelong, and that's a great resource. And just recently, the anaesthetic pathways for adults with intellectual disabilities, so they can have services that were previously unavailable to them, such as the flu shot and blood tests. And that's going to be a real bonus for GPs looking after people with complex needs. The CHAP tool, those annual health assessments, which was previously quite cumbersome, has become a little bit more streamlined and a bit more accessible, and is going to become more of a part of our everyday professional tools that we can use to look after people with an intellectual disability, and that's going to cause a great outcome. And also leadership from the Westvic PHN, including the SPIDAH team, which I think has been fantastic just over the course of this SPIDAH project, and hopefully that can continue. Because really that ongoing advocacy has to come from sort of health organisations, and we have to, as individuals, not just accept that the current system that we've created is being adequate, and that there is a better way forward, and that'll have a better outcome for what can be very vulnerable members of our community. So look, thanks again for letting me to be involved in the SPIDAH project. It's been a really great experience. I've got to meet so many fantastic people, and I hope the work, the Westvic PHN and the SPIDAH project just continues to grow, and that the health outcomes for those people with an intellectual disability in our community improves over time as systems improve. So thanks very much, everyone, for your interest and your care. Thank you.
Thanks very much to Robert. He's been an absolute stalwart of the SPIDAH project throughout, and he was also a presenter at our annual general meeting last year. So, yeah, a great advocate and fabulous GP. We're going to move next to Andrew Pridding, and we've got Andrew and Amanda, the next two speakers, and both of them are actually live with us. So as they go through, people might want to think of questions that they may have, because we will have a little bit of time for questions. So maybe if you pop them in the chat or put your hand up, once we've gone through Andrew and then Miranda, we might have a little bit of time for some questions. So just giving Andrew and Miranda a heads up that there could be some questions coming. So Andrew Pridding is qualified as the first dual disability nurse practitioner in Australia, and I think he's only the second one in the world as far as we know. So as a nurse practitioner with St Vincent's Mental Health Service, Andrew works with people with both intellectual disability and mental illness, and will have capacity to prescribe some medications and consult on assessments and treatment plans for clients. So Andrew's been involved in the project for quite a long period of time now, and I'll hand over to Andrew to give his thoughts about his involvement and what learnings he'd like to share. So over to you, Andrew.
Thank you, Andrew, for the introduction, and thanks to Kerry and Nicole for involving me in the project. I'd like to recognise their commitment and passion for this project, which has been quite incredible, and for the making my involvement so easy in terms of the organisation and arranging for events to occur. I'll just begin. So I've not done a PowerPoint presentation. I'm trying not to use them anymore. So I'll just reflect on my involvement in the SPIDAH project, and I'll begin by introducing the dual disability service for those who aren't aware. So we're a specialist mental health service established in around 1999 in recognition of the gaps in mental health care for people with intellectual disability. And the aim of our service is to enhance the capacity of Victoria's public mental health services in relation to intellectual disability mental health. And we do that by providing assessment for consumers of area mental health services, and then providing consultation on treatment, planning and training for mental health clinicians. We were initially approached by SPIDAH to explore concerns around mental health care for people with intellectual disability. And the current philosophy really is that people with intellectual disability have the right to the same mental health services as everyone else, although they might require additional support to be able to do that. And I think Robert mentioned the concept of reasonable adjustments in the previous presentation, and what we recognized fairly early on is a lot of these reasonable adjustments just weren't occurring. People with intellectual disability weren't able to gain access to mental health care that they required. And there were a range of barriers that explained that difficulty accessing those services. Not least was the lack of knowledge and expertise of mental health clinicians, people working in mental health sector, about intellectual disability in general. There's no real training in undergraduate qualifications. There's very little in the postgraduate education available, and many mental health clinicians lacked contact or experience of working with people who have an intellectual disability. And there tends to be this process whereby people with an intellectual disability and their families or carers approach mental health services seeking support, often in serious need of supports, and are then turned away with the comment that their problems are all related to their intellectual disability, or that term that it's behavioural, somehow conveying that all their what they're experiencing can be explained in terms of their environment or learned experiences. And that was leading to a lot of people who had genuine mental health concerns being turned away from mental health services and supports. And it quickly became apparent that there were major barriers across the whole continuum of care, right from primary care through the specialist mental health services, and that the barriers existed across the whole service system. We did identify a number of specialist services, but these services really are very fragmented with limited collaboration, and have almost been set up in a way that they operate as almost independently of each other and the wider service system. So, for example, we have the Victorian Dual Disability Service, which aims to support specialist mental health services. We have the Centre for Developmental Disability Health, which aim to support primary health. And then we have a range of other services, such as the mental health intellectual disability services, which are located in the Alfred mental health area and Monash mental health area, and the transition support unit. So a lot of specialist services, but very small, isolated services with limited connectivity. And that really isn't in the best interest of people with intellectual disability, who need a holistic whole of service response to address what are considerable mental health needs, most of which remain unmet. So in keeping all those considerations in mind, the Victorian Dual Disability Service and SPIDAH engaged in a range of collaboration and consultation to try and look at ways of addressing those huge gaps and needs. And what we looked at was providing some, we're involved in a survey of health professionals' knowledge and attitudes in relation to intellectual disability, mental health. VDDS provided a range of training inputs into the ECHO series, which we felt were very well received. But one of the findings and one of the things that was reported as frequently being a problem was that health professionals were saying the information they were receiving wasn't allowing them to be able to effectively identify and recognize when someone did have a mental health problem that needed treatment or management. So the information they were receiving wasn't fitting with the types of the information they required in terms of patterns of signs and symptoms that it would allow them to identify, well, this is definitely a mental health problem and this person needs treatment, or they need to be referred on for more specialist assessment. And so there was a major disconnect between the types of information being received and what clinicians were seeking to allow them to make those decisions. So I think what triggered then the next stage of that involvement was Kerry approached me seeking information about what screening instruments or methods may be available to help in allowing people to more effectively communicate their distress and their problems to health professionals, to allow that that next stage in terms of deciding how to help people in the best way possible. And we looked through a number of different tools and assessments and decided there wasn't really very much out there that was that good. One of the things we did identify, though, was the and really this was based on my involvement with a project 20 years ago, whereby the Department of Health and Human Services had contracted Steve Moss to train BIST team clinicians in using the mini PASAD instrument. And so quite a significant investment was made in bringing Steve Moss over to Australia from the UK, training up BIST clinicians in using this tool, but it would never seem to have been used. It was never effectively rolled out, and there seemed to be never much investment made in continuing that project to allow it to be effective. But what I thought was that this seemed to be quite a good instrument to use, particularly the PASAD checklist, which was designed for carers and families of people with intellectual disability to identify and report mental health issues. And so we approached Steve Moss and had a number of collaborations and discussions with him. He was initially quite reluctant to get involved. And I think Kerry did a lot of persuasion, and we eventually managed to get his engagement. What he identified, though, is that when he'd undertaken training previously, this had generally been for professionals who had an underlying understanding of mental health. And so he identified that for any tool to be effective, the people administering it would need to have some basic understanding of mental health. And that led to us developing, in collaboration with SPIDAH, a training curriculum that covered a range of key topics that Kerry has previously discussed. And so the VDDS collaborated with SPIDAH in developing the training curriculum, and we've delivered that. That was included a range of webinars on a variety of topics in relation to intellectual disability, mental health, and also a face-to-face training workshop that we delivered in Ballarat. There was a very good level of engagement. VDDS provides training and education for mental health clinicians on a regular basis, and we tend to have quite a large difficulty getting people to attend. We often have a lot of registrations, and when the time comes to deliver, not many people show up. There was very good attendance at all the webinars, and the face-to-face workshop, I've got to say the participants were really passionate and engaged in that workshop, which was predominantly aimed at a deeper examination of assessment, mental health assessment for people with an intellectual disability. And I think that based on the feedback and the engagement, there are good grounds of continuing that education provision should the sufficient funding be available to do that. And we would strongly advocate that education's rolled out across the state. So some of the issues that arose during that training that were highlighted were the fragmentation and complexity of services in the system, and how could people with an intellectual disability and their families possibly be expected to navigate the highly complex and fragmented service system that currently exists in Victoria. It's really hard to navigate this system. The lack and increasing difficulty accessing private health options, which are becoming very scarce. Difficulty accessing mental health supports across the whole service system. Continued siloing of services, whereby people say that, well, this is due to an intellectual disability and therefore it's NDIS problem, or this is due to a mental health and it's clearly not our problem, this is for mental health, and people falling through the gaps in services, which is still occurring. The lack of knowledge and expertise about intellectual disability health, both by mental health clinicians and across the whole service system. There's still a high degree of exclusion and discrimination occurring, and people are excluded from services on the grounds that they have a disability. And the lack of specific policies, guidelines or pathways. Even until very recently, there was an absence of intellectual disability content in most mental health policy or legislation. And still today in local mental health service policies, guidelines or pathways are absent in relation to intellectual disability. So following the completion of this training, the training was delivered by Steve Moss, who's developed what I think is a really well designed adaptation of the Moss Pass checklist, which is the update of the PASSAD checklist, to allow it to be administered by primary health clinicians and providers to obtain a very good description of mental health signs and symptoms, and for those people who are administering it to develop an initial formulation about mental health that can then be used to determine whether someone might need intervention at a primary health level or need referral for more specialist assessment and management. And I think it's a really good tool. We now have a good, well-designed tool and a well-informed workforce to administer it. I think the key now is to increase the number of people who are able to use that instrument, because I think there's a very big risk that it would go the way of the previous training delivered 20 years ago, whereby if it has insufficient support, it will just disappear and not really be well used. So I think it needs to be ongoing. There needs to be ongoing funding for this initiative. I think there needs to be sustainable. There needs to be a locally trained trainer for the checklist. And I think we also need to consider additional training in terms of the MOS Pass ID, which is then semi-structured informant-based assessment that could be administered by mental health nurses and GPs based in practices, to sort of so that the checklist would be the initial aspect, then maybe the mental health nurse or the GP could use the more developed, the more advanced tool to further work up the person, and that would then lead to very well informed referrals to specialist mental health providers. The other thing that needs to happen is mental health clinicians need to know about the instrument, or they'll just dismiss it. So there needs to be training rolled out to mental health services, which would be fully within the remit of our service to deliver that. And I think finally there needs to be establishment for some forum whereby those people who have received training and those people who have been trained in this instrument can get together to develop and maintain inter-rater reliability and use of the instrument they've been trained in, to provide a level of peer support and review, and to improve interagency collaboration and collaboration between service providers. And so that's a very brief review of our involvement with SPIDAH. Again, I'd like to thank Kerry and Nicole for their involvement and making it so easy to be involved, and for their passionate advocacy for people with intellectual disability who have additional mental health needs.
Thanks very much, Andrew. And as I mentioned, if people have got questions, maybe pop them in the chat or put your hand up after Miranda's presentation. But yeah, I'd just like to thank you for your engagement in this project, and just to emphasise that people with intellectual disability, the ability to communicate that they have got a mental health condition, it is so difficult, and we know how difficult it can be to get mental health treatment if you don't have an intellectual disability. So you can imagine how tricky it is to get that level of understanding to make sure that people are properly cared for. So thanks very much, and please stay with us, and we might have some questions in a moment.
Thank you.
Okay, so our next speaker is Miranda Bain. So Miranda is a special advisor in the Office of the CEO of the Court of Victoria, so covering all court services in Victoria. Miranda has worked in international public relations. Since 2003, she's been working as a strategic advisor in justice and the courts, bringing together government, courts, the legal profession, local government and not-for-profit sectors to deliver programs which have transformed traditional business models within the justice system. Her passions are human rights and the environment, and her specialties in communications and community engagement. So I'll hand over to you, Miranda, to just talk about your involvement with the project and, you know, particular learnings that you'd like to share with us. And you're just on mute at the moment, Miranda.
Isn't that always the way? I apologise. After 3 years, you'd think you'd know. Okay, I would like to acknowledge the traditional owners of the land on which we meet. On my land, it's the Wurundjeri people of the Kulin Nation. I recognise the continuing connection to land, waterways and culture, and pay my respects to elders past, present and to emerging leaders. I also extend my deepest regard and respect to any Aboriginal person who is with us today. I have to join the long line of people who have to thank Kerry and Nicole. The SPIDAH project has been awesome. It's made me feel a little bit inadequate because I couldn't seem to catch up with the number of webinars and educational resources and the talks and the engagement and the people and the nurses and the doctors and everyone that came on board. The approach has just been gobsmackingly, awesomely inclusive. And that is, I take my hat off. That's just extraordinary. So in a nutshell, The charter arose from the work that we did with the Human Rights Advisory Committee, which belonged originally to Funds in Court, which is a division of the Supreme Court, and is now part of the Court Services Victoria, and is known as the Disability Advisory Committee. The charter grew from a human rights obligation that I think we all share, so that all people with a disability have their right to parent their children. So in 2016, it's been a long journey. We examined the prevalence of people with a disability, in particular intellectual disability, who came into the courts and where, regrettably, they lost the right to parent their own child to out of care home. And often this was the last time they would have that joy of raising their own bubby. The issue for us was that the professionals involved believed that a person with an intellectual disability could not be shown or learn the skills necessary to raise their own children. That is a completely erroneous belief. This early inquiry also involved child protection, because you can't do anything without having child protection involved when you are examining or trying to understand how beliefs come to be. The work in developing the charter specifically was over a 2-year period, and it showed a lack of knowledge about a person with a disability, in particular an intellectual disability, by the professionals who were involved with them. The partnership approach with child protection also involved a pilot with Twiddle, Bowen Health, and child protection concerning mums and dads. So that happened about a year or two ago, and SPIDAH were instrumental in being able to help our Twiddle staff in understanding how to work a little bit better with a person with an intellectual disability. And those people, mums and dads in that pilot program, they wish they'd had known about the charter. Many of them had lost already a child or two to child protection. And I think the thing that is so heartbreaking in the many stories that we heard is that if you lose your child, you've lost your child. You don't get the child back. So, you know, one of the women that we work closely with, you know, she's allowed, her child now is 12, and she's allowed to visit the child, I think, for an hour every 2 weeks. She runs her own organisation. She's a brilliant, brilliant woman. And you know, what we're going to do about that further on down the track is we're just going to have to change the legislation, I think. So the purpose of the charter broadly is for rights for the charter, which I'm assuming we're going to have links to the charter that's available. Yeah, I'm looking at. Good, great, thank you. The purpose of the Charter of Rights for Parents and Carers who have an involvement with child protection in Victoria is to affirm the United Nations Convention on the Rights of Persons with Disabilities, which specifically sets out to promote, protect, and ensure that the full and equal enjoyment of all rights and fundamental freedoms by all persons with disabilities, and is to promote and respect for their inherent dignity. I really like the word dignity, respect, rights. It also acknowledges our own Victorian Charter of Human Rights and Responsibilities. There were many individuals who we consulted around the principles of the Charter, and they included people with an intellectual disability or cognitive impairment, some with an acquired brain injury, developmental delay, autism, mental health disorders, or a combination of those elements. Many of those individuals have had an adverse involvement with child protection and endorsed the Charter and the key principles. If I go to the distribution, the Charter was launched in, oh, thank you, Nicole. I'm going to miss you. The Charter was co-launched with the Department of Fairness, Family and Housing and Child Protection in February 2022. So you can see, can kind of hear that the endorsement of the Charter by Child Protection with this department is critical to its success. and I'm very, very grateful, frankly. But the ability of the Charter to change attitudes cannot be underestimated. It's a wonderful tool. It's a wonderful way of bringing people together to have a conversation about something which is really important to them, which is their bubby. You know, they want to raise their children. And when you know that the belief that existed certainly in courts and certainly within the profession of child protection was that they couldn't be shown or they couldn't learn those skills, and that is just so terribly wrong. You know, you have to kind of, it takes a while to kind of absorb that as being an historical fact. We've seen a few of that around the place. So the Charter has been promoted to Victorian GPs via, it's in a link to a newsletter that the Royal Australian College of General Practitioners sent out. I think it's been mentioned twice there. It's available from DFFH, Child Protection. It's available and has been promoted and used in metro and regional local councils. Every major disability organisation has been met with and developed the Charter. Other disability organisations have been talked with and have access to the Charter, and I'm still meeting with them. It's available to maternal health and welfare nurses services and so on. It's been discussed thanks to Kerry and Nicole in many webinars and podcasts, and it's been written about in legal and law articles because we needed to, you know, softly educate legal practitioners around the rights, the human rights of people with an intellectual disability. We're currently developing, again with the department, an Aboriginal and Torres Strait Islander version of the Charter, because their sense of community and how they work as a community in raising their children is quite different to us. The next version has been drafted by the women's collectives in Mildura, Swan Hill and Robinvale, and has been distributed to back to DFFH. And I have to say it's a slow process, you know, but we want to get it right. So we're walking alongside our Aboriginal and Torres Strait Islander colleagues in the development of this new version. I'll go back to child protection because it's just been such an interesting conversation. You know, in life you have an interesting conversation, you just think, oh my goodness me, I would never have thought that. So the Charter is a tool to bring parties together. It is front and centre of the new induction program for child protection workers. Danny, I talked with yesterday, the DepSec of DFFH, he says it's been a wonderful, liberating experience for his staff because they've got a way of talking and using the Charter when they're with a person with an intellectual disability or other disabilities, and it's a liberating tool. You know, it's an interesting kind of, you know, reflection, isn't it? And it acts as a lever to promote the person's rights and encourages respect and regard for that person who identifies with a disability. And it also respects the rights of the child protection worker in that space, right? So they have to communicate, they have to collaborate, and they have to work through. We know the tool is being used by VLA lawyers, and the tool is stopping babies from being taken from their mums and dads and put into out of care home. Like it's a wonderful thing to know that. So the Charter took a lot of consultation, you know, and hundreds and hundreds and hundreds and hundreds of hours of work. But the conversations enriched us to come back with principles that both suited the parties, both parties, child protection, what they could do legally, and what they could do in terms of their own resources, and also what the expectations, how to make realistic or realise the aspirations of the parent in the room with a child protection worker. That's working. So what I wanted to say, because of course I never take too much notice of time, so I'm hoping that someone's, you know, because I can wave my hands around and talk forever. Oh, comes from a large family, sorry. 6 children, what can I say? Not everyone, coming from a large family, trust me, this bit's true. Not everyone is born equal. Come from a large family, you know that. The older one gets everything. That's my view. I was number 5 out of 6. Oh, more peas on the plate. The arguments. Not everyone is born equal. Yeah, good. But everyone has the undeniable right to have the human rights respected. That's our job. You know, that's our obligation. I think we share, everyone in the allied health and health services. You get that. You know, you get that everyone's human rights have to be respected, and they should be treated fairly, and they should be treated with the highest of regard. And we, on this part of what we do, we have an obligation to promote and to safeguard those rights. That's our job. So the work undertaken by SPIDAH, as I've said, made me feel often inadequate because I just couldn't keep up. And I'm very competitive, coming from a large family. You get that, of course. You open up the window. You know, you open up the window to this awfulness that existed for someone with an intellectual disability, to have their voice heard, you know, critical, have their voice heard. It doesn't take long, you know, you just have to spend a little bit more time to listen. They, you know, just a little bit of time, not a huge amount, because once you get to work with them, you get to know them. And Aunty Jane talked about trust is a critical bit to this. If there's a trust between the parties, then you get to know them, then you understand better what it is that they're trying to say. The professionals working with persons with a disability can increase their knowledge. That's the bit, you know, it's just been extraordinary seeing the webinars that are the educational resources, everything that's available for us, the professionals, working in the space. And what a wonderful outcome that is, that you can increase the life expectancy of someone with an intellectual disability. That's an awesome gift. You know, it's just wonderful that you're able to do that. So that they can live a better life and they can fulfill their own aspirations. You know, that's wonderful. But there's more work to be done. There always is. The SPIDAH program needs to be funded more. It needs to be rolled out across the state of Victoria. I've written to the minister. I sort of got a cursory, you know, acknowledgement back, but I'm up there in 2 weeks. I'll drop by like I normally do and knock on someone's door and say g'day, and if I don't get thrown out of Parliament, which is, I don't think I've ever been thrown out of Parliament yet, but assuming that doesn't happen, I'll just rock up and just say, come on, we need to keep it going. Our work now is what we want to be able to do with the help of Kerry and Nicole is to have disability workers trained so that they can support a mum and dad pre-birth, birth, up all the way up to kinder. And that support worker would be ideally placed, because again, to be with that person through, hopefully throughout the major part of that journey. And that's going to take a bit, you know, to organise. It's very possible. I've written to Bill Shorten and others, just pointing out that it would be a very good step forward to have capacity built in disability workers so that they can properly support a person who has become pregnant and wants to keep their baby and to be a parent. And we want to really have disability support workers better skilled because we're going to need them as we go forward. We're just going to have to need them because we are not a lot of people in Australia and we can do so much, but together, which is the main lesson I've learned from the SPIDAH group, is that together we can make just a huge difference in this area. And the world would be a better place. That's what I figure. It just would be a better place. So that's probably about, I don't know, have I gone over or under, or you know?
I think you're just about right, Miranda. Thank you very much. Yeah, and I think the point you made about, you know, getting over preconceived notions and so on is something that we sort of see also in First Nations space, that there's this process of unlearning and relearning it. So, you know, getting rid of the things and the perceptions and the, you know, latent beliefs that we might have, and having an open mind to learn a different way. And I think that's what you're really talking about here with the rights that individuals have. So yeah, no, really terrific. So thank you very much.
My pleasure.
We've got a little bit of time if there are questions. There's nothing in the chat as yet, but is there anybody with a hand up that would like to ask a question? So we've got Tyrone. Tyrone, do you want to jump online, and whether it's a question to Andrew or to Miranda?
Thanks, Andy. It's probably a comment as well, but I mean, what a great project. So it's a real credit to the PHN, and I'm biased being a director on the PHN, but this is really fantastic work and to see it in operation. So a shout out to all of you who've worked on this project. It's just terrific. I did have a question about the interaction with the NDIA, because we often talk about the NDIA only supporting people with disability up until the hospital car park. So to get primary care and get support workers into that primary care environment is very difficult, and the NDIA are very reluctant to put support workers in that hospital system to support those individuals with disability. So I just wondered whether there was any interaction with the NDIA at all.
I might throw that to Kerry and Nicole as to how engaged they've been with NDIA and how willing they've been to get involved.
Yeah, absolutely. We've had quite a very good relationship with the NDIA, and they've been or come involved in most of our collaborations. With this one in particular that Miranda's just been referring to, I know Stephen Bell is online at the moment from the NDIA, so thank you, Stephen, for attending today. And Stephen and some of his colleagues certainly participate in the discussion. And where there are things like, for support workers in particular, you can get a change of circumstance to a person's goal if they actually are in receipt of NDIS funding to help provide support as a support worker to a person with lived experience of a disability. So it's an area that we think that there's more opportunity to actually head into for that upskilling in various areas, and also in hospital as well. One of the other people that's been involved in the group is the Kylie from the Triple P group, which is a self-advocacy group for parents with a disability. And Kylie also informs that the journey that she's been involved in as an advocate has also been there to support. So the NDIA certainly have started looking at resource opportunities, and that would be a part of our advocacy in our final report to be able to do that. We also have, they've just been great. They've delivered some things in terms of the interface between GPs and NDIS and how that they can build better capacity. So yeah, we'd have to say that they've been very much involved in our project and are willing to listen when we actually put some ideas out there and hear and get some good data about how we can move forward in this space.
That's so great to hear, Kerry. Thanks for that. And it's also, I mean, sometimes we get preoccupied with the cost of the NDI system, but don't look at the scheme cost of someone's health,
yes,
you know, and the long-term life cycle health of those individuals. So But thank you for that response, and congratulations, Kerry and Nicole. Awesome
Thank you very
job.
much.
Really terrific.
Thank you.
Thank you.
Thanks very much, Tyrone. And apart from Tyrone being a director of Westvic PHN, he's also CEO of McCallum Disability Services. So this is very, very close to his heart. So, and he's been a great supporter of the SPIDAH project. So thanks, Tyrone.
Andrew, I'm happy to just talk about the role that the SPIDAH program has played with the NDIA, because a lot of being involved in the regular project steering committee and things like that, it's been fantastic to actually hear stories, hear themes, hear issues that are actually happening on the ground level. And these kind of themes, I'm in the community engagement team for VicTAS, and we see the community engagement as a two-way process. So we're there to actually provide information, provide support and things like that. But it's also we're there to collect information, so collect challenges and collect things. So a lot of the conversations that we've been having that have been highlighted by Kerry and Nicole and the other steering group committee meetings members have actually fed back to me, and I will feed them over to different policy areas and different areas of the organisation. So it's I think it's not a one-way process in the sense of we supporting the program. The project has been supporting us in a lot of ways also.
Great, thanks very much, Stephen. I can't see any other hands up at the moment, so we've got one more presentation to go. So I'll introduce that next. So Heather Miller is a disability practice nurse. She originally trained in the UK, and currently she's a practice nurse at a busy GP clinic, working alongside or supporting patients with intellectual disability alongside general practice development disability specialist. Furthermore, she's involved in the Centre for Developmental Disability Health at Monash, and is a disability resource breastfeeding educator with the Australian Breastfeeding Association on breastfeeding and Down syndrome. She has her own lived experience of a 8-year-old son with Down syndrome, and accredits him with her depth of learning and understanding. So Heather couldn't be with us today, but we've got a short recording from Heather. Nicole, I think it's on mute at the moment.
Hi, my name is Heather Miller, and I'm a disability practice nurse working in primary health with a general practitioner who specialises in developmental disability medicine. I also contribute to projects that promote the health needs of people with disability and have a lived experience with my son who has Down syndrome. My involvement with the SPIDAH project was to facilitate workshops for GPs, practice nurses, allied health professionals and primary care practice staff to increase an awareness of how to provide health care to patients with intellectual disability using case conferencing as a model of wraparound care. So why case conferencing? Case conferencing provides a holistic approach to care. It is an effective tool in managing the health needs of people with intellectual disability. It reduces and aims to remove the silos between general practice, allied health, hospital, specialists, nurses, community health, mental health, and emergency services. This model provides preventative rather than a reactive care process, a continuity of care, an awareness of the roles and or services provided by other health professionals, a whole-of-life healthcare approach, collective goals, and it minimises or prevents misconceptions, misunderstandings, gaps in knowledge and skills, and barriers to healthcare access. So this collaborative practice strengthens health systems and improves health outcomes. The relevance of this for the intellectual disability population is paramount given a higher incidence of health needs manifesting and more commonly presenting to health services in advanced stages of disease. So the workshop sessions provided attendees with information on the role of the general practitioner, the practice nurse, and the primary care practice team, including administration, in facilitating the case conference process and to understand the value of case conferencing in providing multidisciplinary health of people with intellectual disability, the value of case conferencing in providing multidisciplinary healthcare of people with intellectual disability, how to arrange a case conference, so identifying the relevant professionals and supporters of people with intellectual disability based on outcomes of an annual health assessment and a chronic disease management plan, and how to lead and facilitate case conferencing and how to document the actions. So some of the learnings that I'd like to share from the workshops that we held, I really hope now that the attendees had the knowledge and skills necessary to work through this model of care. The attendees included general practitioners, practice nurses, practice staff, and managers and allied health professionals. The workshop sessions provided information about the tools to support health inequalities for people with intellectual disability. So before we even looked at the case conference workflow in our workshops, the attendees learnt how primary care practices approach how to support a patient with intellectual disability accessing their service. So we discussed how do they gain informed consent from the patient or their representative if they weren't able to provide that consent, what support was needed for the person when they access the primary healthcare service, how to prepare the person for appointments, and look, just thinking about the language and how they communicate. Looking at developing a reasonable adjustments plan. It's not, so for example, for them not having to wait in a busy waiting room if this caused increased anxiety. What are their likes or dislikes, for example? When booking appointments, just the consideration of time. So does it need to be done over more than one appointment? Does it need to be earlier in the day or when the clinic is less busy, or even via telehealth? Supporting decision-making and how the person works through that, whether it's with a carer, family member, or with the practice nurse or GP. So we talked about looking at a comprehensive health assessment tool, then how we review those health outcomes from that assessment with the family, the carer, including the person. And then we looked at how, from this, creating a health action plan or a chronic disease management plan to establish health goals that will assist in meeting their identified health needs. And also looking at how identify the providers and services who can support the person in meeting those goals, and looking at creating those team care arrangements. And after identifying healthcare goals, consideration of how a person's NDIS plan may support them if they had disability-related health needs. So, for example, we know that people with Down syndrome are more likely to experience obstructive sleep apnea because it's a disability-related health need. Identifying the need for case conferencing with providers in the team care arrangement, but also with medical professionals, home and community service providers, supported disability accommodation providers, NDI support coordinators, disability support workers, families, carers, and the person. The timeline of frequency for case conferencing was discussed, and also looking at the correct documentation and the procedures are in place to meet the medical benefits scheme requirements. So we then discussed looking at the workflow that general practitioners and practice nurses undertake in primary care services. So I've already mentioned undertaking comprehensive health assessments, and really, as I mentioned before, it was around identifying the health needs and determining a baseline of health for that person, And we looked at the CHAP, which is the Comprehensive Health Action Plan, which is now freely available and downloadable from the Federal Department of Health website. And then from that, we looked at the goals that were identified or that you may identify from completing a comprehensive health assessment. And then from that, you're able to then develop a chronic disease management plan. And because we know that many people with intellectual disability will have more than one chronic health condition, we looked at, from that plan, identifying health professionals, practitioners, allied health, to then support reaching those goals or meeting those goals with that person. And also inviting medical, nursing and allied health professionals to participate in a team care arrangement. Again, also working towards meeting the person's health goals. We discussed the enhanced primary care and also looked at, as a multidisciplinary care team, this is the stage in which case conferencing is engaged to manage those ongoing health needs and goals that have been identified from those previous processes that I've just mentioned. So although it's arranged and initiated by the GP, it's really around supporting the health needs of a person with intellectual disability in a collaborative approach. And really, it's not managed in isolation. And that's the beauty of engaging the case conferencing model of care, that it's so many people, so many services that are working towards, including with the person, those health goals to ensuring that they stay well. We also looked at, in more detail, to think about the NDIS and to look at disability-related health supports that the person may require and how that may be able to be managed through their NDIS plan. So, as I said, GPs plan and coordinate the care of patients with complex health conditions through that multidisciplinary care team approach. And we talked about how that can happen within their practice, and the fact that practice nurses are really well placed as they have the necessary skills and expertise to be able to collect that information to then support that health assessment process. And we also looked at the fact that practice nurses can provide support and monitoring between visits to the GP based on what's outlined in the person's chronic disease management plan. We also looked at the particular MBS items that are available for case conferencing and for health assessments and chronic disease management planning for GPs, so that they're able to organise and coordinate or participate in a meeting or discussion held to ensure the patient's multidisciplinary care needs are met through a well-planned and coordinated approach. Attendees looked at a case study to look at how the case conferencing workflow can be implemented in primary care practice, and just to reflect on their learning from the session and how that would actually play out in their everyday general practice. So in conclusion, I would just like to provide some final comments around what needs to happen next to continue to improve the health of people with intellectual disability and complex health needs in primary care. So this approach to healthcare, so that case conferencing as a model of wraparound care for people with intellectual disability may not be fully recognised by general practitioners, or they just may not appreciate the benefits to healthcare that this service provides. So I feel that education is key, and making primary care aware of the health needs of people with intellectual disability, including mental health, that they're more likely to experience, the tools that are needed, so the health assessments, care planning, knowing how someone is supported by their NDIS plan, and the provision of the NBS scheme to fund the work of general practitioners to undertake comprehensive health assessments, developing chronic disease management plans, and engaging in case conferencing as a tool to provide ongoing support and ideally preventative health practice for the intellectual disability population. So I understand and acknowledge, and we talked about the fact that time pressures that many GPs face. I believe that Key to implementing this model of care is best placed with practice nurses. Their role in general practice means they're involved in making reasonable adjustments to deliver patient health care. They support the GP in completing comprehensive health assessments. They help support review the goals as outlined in the chronic disease management plan. And practice nurses are able to drive the administration involved to engage case conferencing as a tool for both managing a person's health needs as a preventative health measure within a multidisciplinary team care setting. I really enjoyed my time working on the SPIDAH project, and I do hope that many of the outcomes will be implemented further as we continue to meet the health needs of people with intellectual disability. Thank you.
Great, thank you very much. It's I think it's a really important point of the role of practice nurses in, you know, working through reasonable adjustments in the practice setting. So that brings us to the end of our sort of formal presentations. I'd just like to acknowledge that the whole project's only been possible through the funding received through the Department of Health and Aged Care, and that is part of the commitment under the National Roadmap for Improving Health of People with Intellectual Disability. So that roadmap was released in 2021, and I've been fortunate to be a member of the governance group overseeing that that roadmap. So within the roadmap, there are 116 actions that were identified that the government has committed to undertaking, and the governance group meets every quarter to assess where we're up to on those initiatives. So at the end of last year, in the annual report, there's currently 8 of the 116 actions are complete, 77 are in progress, and about 30 of them are just ready to get started. So it's a multi-year commitment that's been made by the department, which has been great, and it was championed by Simon Cottrell, who was the first Assistant Secretary of the Primary Health branch. And I was pleased to see today that Simon's retired, but his successor, Mark Rodham, was with us for the first hour today. So that's a really good endorsement that it remains a priority for the department. So thank you to Mark and his team for being here today. So I think I'd just like to, say thank you again to Nicole and Kerry particularly, but also to the broader Westvic team, and particularly Claire McDonald as well. The communications team, the workforce development team have all supported the project. One way or the other, we'll make sure that something continues in this space, and we're in dialogue with the department about that at the moment. So I think there's light ahead for us. So thank you to all of our presenters today. It's been a great insight, and congratulations again on the final report to the team. I have got a reminder from Nicole that there is there will be a link posted in the chat around a feedback survey, or you can scan the QR code on the screen now. But there is a formal evaluation of the project being undertaken by ABT Associates. So important part of the lobbying about ongoing support around this is going to be the outcomes of this current project and the assessment of the 4 primary care enhancement projects run across the country. So thank you everybody for your participation today. It was great to see we have over 80 people attending today, and yeah, a final congratulations to Kerry and Nicole. So well done everybody. Thank you.